Hi, I'm Roger Blumenthal from Johns Hopkins. I am the chair of the 2026 Dyslipidemia Guideline. That is really a preventive cardiology guideline. And it's my pleasure to introduce you to Dr. Pamela Mars, who was the vice chair and my partner in crime during this process over the last year and a half.
Thank you so much, Roger. I'm Pam Morris, Vice Chair of the Guideline, and it has been a wonderful 18 months or so working together with really a dream team of Guideline authors. And wow, Roger, what a lot has happened in the 8 years since the previous Guideline. We've had so much evidence that earlier treatment to lower LDL cholesterol levels for longer is more effective to prevent cardiovascular events. We've had new tools in risk assessment. You'll talk in a moment about the new Prevent Risk Calculator. We've had evolving knowledge about LPA as a causal risk factor and its role in risk estimation, and also the role of apoB in identifying residual risk. We have had really a lot of evolving understanding of the role of detection of subclinical atherosclerosis and how that can help us in risk assessment, and also how we can use that to guide the intensity of our lipid-lowering therapy. And probably one of the most important things has really been the FDA approval of 5 new therapeutic agents in the lipid space. We're all familiar with bempedoic acid, which has demonstrated an oral agent with demonstrated cardiovascular outcomes benefits. But we also have 4 new injectable agents. First, inclisiran, a small interfering RNA to lower LDL cholesterol. With cardiovascular outcomes trials in progress, we've had evinacumab, an ANGPTL3 inhibitor for use in homozygous FH. And then we have 2 new mRNA-based therapies to treat familial chylomicronemia syndrome and prevent recurrent pancreatitis. So really an exciting 8 years in the lipid space. I wanted to turn it back to you, Roger, just ask you to talk a little bit about where we've evolved in terms of risk assessment.
Well, Pam, you mentioned the word prevent several times, and this guideline focuses on the new PREVENT equation that was introduced by the AHA in 2023. It's a more accurate assessment of risk. And in the guideline, you and I and our guideline writers wanted to continue that CPR theme of C for calculate risk if there's no documented ASCVD or familial hypercholesterolemia. We calculate a 10-year risk if the age is between 30 and 79. We now have a more robust ability to calculate a 30-year risk for those individuals between 30 and 59 years of age. We talked a lot about personalizing risk assessment with a variety of risk-enhancing factors, and we introduced some new risk levels that for high risk, and that'll be some change for our audience to look through. The main focus is really intermediate risk is now 5 to up to 10% risk. And we just go back again to that shared decision-making between clinician and patients. So there's a lot new in the risk assessment world. And let me turn it back over to you a little bit more about the pharmacotherapy.
Well, I think you're right that the new PREVENT equations have really contributed to more nuance, I think, in assessment of patients for primary prevention. I think in years past, maybe it felt a little bit like all primary prevention patients somewhat blurred into one another. I think the new PREVENT equations and the risk modifiers or risk enhancers that you mentioned are really helping to bring nuance to the primary prevention space. You know, another place I think where the guidelines will talk about some of the different patient treatment groups, those with diabetes. You know, as per usual, we know that all adults between the ages of 40 and 75 are at risk for cardiovascular disease and benefit from at least moderate intensity statin. But it's important in diabetes to really consider some of the diabetes specific risk factors, some of the traditional risk factors, but also now incorporating the PREVENT ASCVD risk estimation to identify those patients who are not only candidates for more intensive LDL cholesterol lowering with statin therapy, but also those who may benefit from non-statin therapy. We also discuss in this guideline the use of apoB, and I might mention that's really in 3 specific groups. The group we're talking about now, which is diabetes, because of the increase in atherogenic lipoprotein particles that can be seen even after you've treated the LDL cholesterol to goal. The other 2 groups are those with hypertriglyceridemia and those who have already achieved their LDL cholesterol goals and non-HDL cholesterol goals, but you want to see if there is any remaining residual lipoprotein risk. The other category I want to mention is ASCVD. Now, we did in the guideline maintain the 2 risk categories of ASCVD not at very high risk and ASCVD at very high risk, with the acknowledgement, as you know, Roger, that there are very few patients who have ASCVD who are not at very high risk. We also introduced lower LDL cholesterol goals for those with ASCVD at very high risk to less than 55 milligrams per deciliter, now really more intensive therapy. Certainly the results of the VESALIUS-CV trial now support that more intensive goal in patients with ASCVD. Other algorithms I'd like to draw attention to, really beautiful algorithms for management of the patient with statin intolerance, those with hypertriglyceridemia, as well as an approach to the management of lipoprotein a while we await the results of cardiovascular outcomes trials with new therapeutic agents. I also want our listeners to dive into the resources that are included for drug selection, drug efficacy, safety, and potential drug-drug interactions, which are very useful components of this guideline. We also do include very specific recommendations for populations such as special considerations in children, older adults, those with CKD, HIV, heart failure, and also for those individuals during conception, pregnancy, and lactation. So really exciting, Roger. I'm sorry I couldn't contain myself.
Well, Pam, you did a fabulous job, as did the rest of the writing committee. We want our readership to really focus in on our top 10 points, but to read through all the recommendations and at least the synopses of each of the sections. And maybe we'll close with the ABCs. A for assessment of risk. We've made some tremendous advances in that with the PREVENT equation, selective use of coronary calcium, and certain biomarkers like HSCRP. We then, if you think of B for blood pressure, we always want to remember the recent AHA, ACC blood pressure guidelines, and they had that same message to start earlier. And after 6 months of lifestyle modification, if you still were above 130/80, that should signify the need to be much more aggressive. And we followed them with that. We want to be more aggressive, and as you said very well, we want LDL lower for longer, and that's certainly going to yield benefits to our patients. So hopefully the readership will like what we put out, and we look forward to the discussions that the guidelines will engender.